Hello, my name is Paul Fletcher. I'm a periodontist and an associate clinical professor at Columbia University, and I'd like to thank Dental XP for inviting me to speak with you on the management of peri-implant disease. I'd like to begin by saying that I think modern-day dental implants are among the most significant advances in the history of dentistry, and that implants make up a significant part of my practice. Having said that, peri-implant disease has become one of the more controversial topics in the field of dental implantology. There are extremely well-respected researchers and clinicians who state peri-implant disease is an infrequent occurrence, while there are equally respected researchers and clinicians who feel we have a problem. I'm one of those who feel we have a problem. At Columbia University, where I teach periodontics and implant dentistry on a postgraduate level, hardly a week goes by when a student doesn't approach me with another case of peri-implant disease. And in my private practice, where literally half the new patients that we see have some form of an implant-related problem, the number of cases of peri-implant disease have also been rising. The research seems to also indicate we have a problem. Research says as the number of implants that have been placed increases, and as the number of years implants have been in place increases, and as dentists with different skill sets are now placing implants, the incidence of peri-implant disease has been rising, and the prevalence of peri-implant disease is increasing. But the research on peri-implant disease is confusing because study methodologies vary. Different studies have different thresholds for peri-implant disease. Different surfaces and different designs are often equated. And some studies look at patients with peri-implant disease, and other studies look at implants with peri-implant disease. And finally, some studies implicate implant or equate implant survival with implant success. So, if you look at this case after 13 years, you can see what it looked like originally and see what it looked like after 13 years. Well, the case definitely survived. Is it a success? Well, that's open to discussion. But does it need treatment? Yes, it definitely does need treatment. As I mentioned, some studies look at patients with peri-implant disease, while other studies look at implants with peri-implant disease. This is a study by Franzen, who is a member of the Lindy Group, and what they did is they looked at 662 patients with 3,400 implants, and they assessed the implants over the course of 5 to 20 years. And what they found is 185 of the 662 patients, or 28% of the patients, had one or more implants with progressive bone loss, whereas 423 out of the 334 implants, or the 3,400 implants, or 12% of the implants, showed progressive bone loss. Thus, if I was a speaker or somebody wanted to emphasize that peri-implant disease is a real problem, I would look at the number of patients, 185 of the 662, or the 28% of patients with peri-implant disease. Whereas I wanted to say peri-implant disease was not that much of a problem, I would look at the number of implants, 12% of the implants in the sample that had peri-implant disease. In any event, if your patient has a problem, you have a problem. So let's start at the beginning and let's talk about the definition of mucositis and peri-implantitis. Mucositis is a reversible inflammatory reaction in the soft tissues surrounding a functioning implant. The key word here is reversible, whereas peri-implantitis is a destructive inflammatory reaction affecting the soft and hard tissues of an implant and function. Thus, the bone is also affected. And this is more difficult to reverse than mucositis. Now, from a historical perspective, we've sort of been lulled into complacency by the early Brannemark research, or the early implant research, which essentially said is periodontal indices, such as bleeding upon probing or pocket depth, when applied to the peri-implant mucosa, may be of little clinical significance when measuring the success or failure of an osseo-integrated implant. And peri-implant disease was rare. Attached gingiva was only needed if the area was inflamed. Now, you have to remember what they were originally looking at was a smooth surface implant, where many of the cases were full mouth cases and the implant abutment junction was high and dry. When we started dealing with rough surface implants, what we found is significantly more peri-implant disease without keratinized tissue, and this was Block in 1996. So, peri-implant disease is multifactorial. There are implant-related properties as factors such as surface properties, the material used in the design of the implant itself, clinician-related factors such as the surgeon's surgical skill and the prosthetic skill of the restorative dentist, and patient-related factors such as predisposition to periodontal disease, systemic medications, oral hygiene, smoking, and bone quality. To me, the key thing that we have to deal with is we're dealing with a unique problem that we really never had to deal with before regarding peri-implant disease. And that's really the macro and micro geometry of the implant itself. The macro geometry of these threads with these concavities that can get debris into the concavities of the threads that make it really difficult to clean and get the bacteria out, and the microgeometry of the implant surface, where in this particular case you can actually see bacteria in the pores and concavities of this implant surface. Microbiology of peri-implant disease says the bacteria around teeth prior to implantation determines the composition of the microflora on implants. And the bacteria in periodontal disease are also present in peri-implant disease. And a key significant problem is implants are being placed in patients with active periodontal disease. Thus, the bacteria, the seeding bacteria, is already there. And the research shows patients who lost their teeth due to periodontitis have an increased risk of developing peri-implantitis. So if we look at this particular case here, you can see this patient in 1999 had a lot of bone loss around this tooth. The tooth was removed, the site was augmented, and the implant was placed in 2000. In 2004, that implant was still stable. But the patient, who was susceptible to periodontitis and a smoker, wound up moving to China. We didn't see him for 5 years, and when he came back, after smoking 3 or 4 packs a day, you can take a look and see the amount of bone loss around this implant. And in 2012, this implant, 3 years later, this bone loss had progressed a bit more. Histopathologically, we also have a problem, because it's been shown that the amount and intensity of bone loss around the dental implant is greater than around the tooth. Now, around the tooth, what we actually have is perpendicular connective tissue fibers inserting into the root of the tooth. Now, these perpendicular connective tissue fibers act as a barrier to prevent the downgrowth of inflammation into the underlying bone. Around an implant, we have no fibers attaching into the surface of the implant. So without these fibers, what happens is the bacteria tend to grow apically in a more aggressive fashion into the bone than they do around the tooth, where we have this connective tissue fiber barrier. And these studies by Lindy and Berglund in 1992 and 2004 show the apical extension of the inflammatory cell infiltrate was more widespread and extended into the alveolar bone around the implants, and the peri-implant tissues appeared less able to arrest progressive plaque-associated lesions. This is a photomicrograph of Dan Boozer's, and here you can actually see the parallel or circular orientation of the connective tissue fibers, and this may lead to a more rapid spread of inflammation in the peri-implant mucosa. So here are the connective tissue fibers approaching the implant, and when they get to the inner zone, this inner zone of connective tissue fibers, right next to the implant, turn and tend to go circularly around the implant. Now, really sobering statistics come from the work of Ludebaker and Klaus Lang, showed that the chances of gingivitis becoming periodontitis are 30%. Whereas the chances of mucositis becoming peri-implantitis are as high as 60%. This is a real problem. Now, this inner zone of circular fibers caused this aggressive bone loss around a dental implant that we just don't see around the tooth. And if you can notice, very often this circular bone loss, or the appearance of this bone loss, is symmetrical, because what happens is the inflammation follows the circular fibers around the implant, causing bone loss, and this type of bone loss that we, as I said, we don't see around teeth. Another problem is the rate of peri-implant bone loss increases with time. Thus, this patient had these implants placed in 2000, not a patient of ours, but she came into the office in 2008, and this is what the implants looked like radiographically. Now, in 2011, she had started to develop peri-implant disease, and we told her she needed treatment, and she got lost, and she didn't go through the treatment, but she returned again in 2014. And in 3 years, take a look at the aggressive bone loss and the rapid bone loss that had occurred around this implant. So peri-implant bone loss is not linear. It can develop and it can spread very rapidly. May not all the time, but when it does, it has the chances of developing and progressing very rapidly. This is a problem. So, in terms of definitions, growth of oral biofilm is facilitated by the design of the superstructure, and we all have cases like this that are almost impossible for the patient to keep clean, the screw-shaped design of the threads of the implant, and the surface modifications of the implant itself, and in other words, the surface texture of those implants. The weak links are the surface and the implant abutment junction. So in this situation where the tissue is flat back, you can see Heiss-Mayfield says the adhesion of microbes to bare and rough implant surfaces impedes mechanical cleaning. So if you take a look here, you can see we actually have plaque and calculus in the concavities of the threads of this implant surface. Now our normal scaling and root planing action is occlusal gingival. But going occlusal gingivally is not going to get into the threads of these implants. To get them clean, you essentially have to go circumferentially around the threads of these implants. And if I hadn't flapped this back and hadn't been able to visualize it, I wouldn't even know that this bacteria and this plaque and calculus were in the threads of this implant. The weak links also are the implant abutment junction. Now, there's plenty of research showing that micro-leakage occurs into and out of both the internal hex and Morse taper connections. And where more often than not is the implant abutment junction, but right at the crest of bone. And if you take a look at this picture here, you can actually possibly see this opening, and you can see in the video, when force is placed upon this implant, how the implant opening and the implant abutment junction torques, and bacteria tends to progress and work into this implant abutment junction. And this even occurs when torquing a Morse taper implant. Not as often, not as much, but there is an opening that's present around the Morse tapered junction. This is a problem. Cement is a real problem. In a paper by Wadwani and Pinero, they said 65% of 185 implants showed evidence of excess cement when examined under magnification. And you can see the existence of cement here, causing this fistula, and the presence of cement here, and this is what this implant surface looked like after this implant was removed. Now, as a periodontist, I would prefer that all your implant cases, whenever possible, are screw retained, because those are retrievable. If there's ever an issue, ever a problem, we can always remove the framework and the restoration and try to resolve the problem that may exist. Much more difficult with a cemented restoration. But if you are going to cement a restoration, and again, this comes from Wadwani and Pinero's group, the question is how you cement these restorations. Do you fully cement them? Do you partially cement them? Or do you just rim them? And they also came out with the concept of using a cementing die if you're going to cement your restorations. And with the cementing die is what you do is you take the final restoration and you put some dye spacer inside the final restoration or lubricant, and you put acrylic, quick setting acrylic into the restoration, and then put a dowel into the quick setting acrylic. Let it set, and once it sets, what happens is you have a die of this crown, of the inside or internal part of this crown. Now, what you do then is you take your cement, and hopefully it's a temporary cement, possibly a zinc-based cement, because zinc-based cement is more radio-opaque, and it's been shown to have some antibacterial activity or antimicrobial activity. So something like a temp bond into the inner aspect of the crown, and then you take the cementing dye, put it into the crown, and that will express any excess cement. You remove the excess cement and then take the crown and place it in the patient's mouth. This can also be done with an elastomeric impression material, where you put a dye spacer into the interior part of the crown, you put the impression material into the inside